The administration of isotonic saline solution in large volumes is associated with the development of hyperchloremic metabolic acidosis. This is also seen in some medical conditions like renal tubular acidosis and after some surgeries. This tutorial explains why patients develop hyperchloremic acidosis and looks at why this may be harmful for patients and explains why you need to avoid giving large volumes of chloride-containing fluids.
Hyperchloremic acidosis. Welcome back. In the previous tutorials, we looked at metabolic acidosis, and I explained that metabolic acidosis is associated with reduced strong ion difference. I'll clarify that again in a few minutes. This occurs due to the accumulation principally of strong anions. Traditionally, these are known as unmeasured anions, and the anion gap is said to be widened. These days, lactate and beta-hydroxybutyrate are easily measured, and the name of the acidosis, lactic acidosis or ketoacidosis, is based on the anion. In this tutorial, I'm going to look at another cause of metabolic acidosis, and that is hyperchloremic acidosis, which is also known as a non-gap acidosis. I'm also going to discuss intravenous fluid and hyperchloremia, and a little bit about the management of hyperchloremic acidosis. Let's start with a clinical scenario. I'm called to the high dependency unit or a high intensity medical unit to see Sarah, who is 19 years old. She was admitted to hospital 6 hours ago with first presentation of type 1 diabetes and acute diabetic ketoacidosis. This is being treated with the hospital DKA protocol, and her blood sugar and ketones have come down a bit, but the nurses are concerned that her acidosis is slow to resolve. These are some of the initial labs. You'll see that her blood glucose was 30 millimoles per litre or 540 milligrams per deciliter. She had a mild lactic acidosis, but the principal cause here was ketones. Her sodium at this stage and her chloride were normal at 140 and 104 millimoles per litre. In this situation, the difference between the sodium and chloride is 34 millimoles per litre. Now let's look at her labs 5 hours later. You can see here that she has a fully compensated metabolic acidosis with an impressive base deficit currently at -20. The anion gap is measured at 20 milliequivalents per litre, so it's wide, but a little bit misleading, as the impact of the ketones and the lactate are only approximately 4 milliequivalents per litre. Renal function is normal. What I want to draw your attention to is this: the plasma chloride level is now 118 milliequivalents per litre or millimoles per litre. Now that's a significant increase in the chloride. Remember, 5 hours ago, this patient had a chloride of 104, so the chloride has gone up by 14 milliequivalents per litre. This represents acute hyperchloremic acidosis, and it has been caused by the resuscitation fluid, in this case 5 litres of 0.9% saline solution. This is sometimes known as normal saline or isotonic saline. Why does chloride gain cause acidosis? Let's look at the mechanisms. There are approximately 146 milliequivalents of cations and an equivalent amount of anions in the extracellular fluid. The cations are easily measured, but the anions are more difficult, and some proportion of the charge is unmeasured or unmeasurable. That includes the charge carried by hemoglobin and metabolic junk products. Irrespective, all of the positive charges must equal all of the negative charges. This is the law of electrical neutrality. In acid-base, we are principally interested in the difference in the charges between the strong cations and the strong anions, and that is about 40 milliequivalents per litre in difference. That difference is known as the strong ion difference. It effectively represents the anion gap plus the bicarbonate, the charge carried by albumin, phosphorus, unmeasured anions, and bicarbonate. The key thing to understand with this strong ion difference, which as I've mentioned is about 40 milliequivalents per litre, is that if it decreases, there is a surplus of negative charge over positive charge. This affects water dissociation to express positive charge on water particles, hydrogen ions if you will, and this results in metabolic acidosis. Electrical neutrality must always hold. If the strong ion difference increases, there is a surplus of positive charge over negative charge, and this results in metabolic alkalosis. So let's look at strong anions versus strong cations. The principal component of the strong ion difference is the sodium and chloride charge. It is important to understand that although the absolute concentration of sodium and chloride are not fixed, they vary from patient to patient. The relative ratio is always, under normal circumstances, between 1.35 and 1.38 to 1. Also, remember that these are the major components of extracellular osmolality. The number of osmoles provided by sodium and chloride are usually between 240 and 245. Any change in the relative ratio of sodium to chloride will impact both the strong ion difference and by inference the acid-base status, but also the extracellular and indeed intracellular osmolality. So the normal gap between sodium and chloride is between 35 and 38. Essentially, this is the highest the sodium and the highest the chloride is likely to be under normal circumstances, a sodium of 140 and a chloride of 105, with that gap. The gap being, of course, filled by the albumin, phosphorus, and bicarbonate. The ratio doesn't change. For example, in this picture, the sodium is 135 and the chloride is 100, but the ratio is the same, the difference is the same, and the charge that's carried on albumin, phosphorus, and bicarbonate is the same. A point I'd really like to make, though, is that anion levels are really robust in the body. Under normal homeostatic conditions, the bicarbonate doesn't change much from 24 millimoles per litre in arterial blood, or what is normal for that patient. Obviously, it's going to be higher if they have COPD, but it's usually there. The chloride essentially never exceeds 105 millimoles per litre, and it never goes below 100 millimoles per litre. The relative charge between sodium and chloride is locked at 35 to 38 milliequivalents per litre. I'm going to illustrate this by looking at a stylized example of how upsetting the sodium to chloride ratio may occur. The most important mechanism is iatrogenic. You're in the operating room and you're looking after Henry. Now Henry is 50 and he has end-stage kidney disease, and he goes to the operating room for a kidney transplant. He's anuric and he was dialyzed yesterday, but because everybody seems to freak out about the frankly negligible potassium content of sodium lactate solution, he is given 3 litres of saline, 0.9%, in the operating room as volume preloading for the transplant. Unfortunately, the operation is cancelled because of problems with the donor kidney. What would his blood gas look like? Now, I don't have a specific blood gas to hand, so this is purely illustrative. Imagine that this is the baseline situation. The normal sodium, potassium, and chloride levels are illustrated. Sodium of 140, potassium of 4, chloride of 105, with a sodium to chloride ratio of 35, balanced by the albumin, phosphorus, bicarbonate, and some unmeasured anions. Now he's been given 3 litres of saline that contains 462 millimoles of sodium, 462 millimoles of chloride, and nothing else. No phosphorus, no potassium, no magnesium, no calcium, nothing else, no sugar. Some of this will be lost as sweat or into the gastrointestinal tract. My guesstimate as to what will happen with the gas is as follows. The sodium will increase to about 150 milliequivalents per litre. The chloride will increase to 125 milliequivalents per litre. And then the sodium to chloride ratio will fall. That is, the sodium minus the chloride strong ion difference will fall to 25 milliequivalents per litre. And that is a large drop in the strong ion difference. Now, as I mentioned, a fall in the strong ion difference means metabolic acidosis. And now we must have an electrochemical imbalance. To maintain electrical neutrality, Henry must shed anions and gain cations, but his kidneys aren't working and he's sitting in the recovery room hyperventilating. Remember the law of mass conservation. There are only a limited number of charged particles in the body. Some of these cannot be created or destroyed. The first thing that you will notice is that the potassium rises slightly. This is one of the reasons why potassium rises in metabolic acidosis, electrochemistry trying to balance electrical neutrality. But that has a minimal impact on the cation to anion ratio. There are still too many cations. The IV fluid will have a dilutional effect on the charged particles that have not been included in the IV fluid. So the albumin falls and the unmeasured anions fall, but the bicarbonate falls by a magnitude greater than you would expect from dilution alone. This is because bicarbonate has mopped up, as traditionally described, hydrogen ions that have been generated by a reduction in the strong ion difference consequent of a rise in the chloride. This is the major manifestation of hyperchloremic acidosis, and the base deficit is -5.
I want to go back now and look at the anion gap. The anion gap has been around since the 1950s, and it's based on the concept of electrical neutrality. The sum of all the positive charges must equal the sum of all the negative charges. The sodium plus the potassium, I use the potassium, some people don't, minus the chloride plus the bicarbonate is between 12 and 15 milliequivalents per litre. Most of that gap represents the charge that's carried by albumin, roughly 11 milliequivalents per litre. It depends what the albumin is. It's the total quantity of albumin in grams per litre divided by 4. So if the albumin is 44 grams, then the charge is 11 milliequivalents. And the charge carried by phosphorus is about 1 milliequivalent per litre. The rest is a series of unmeasured anions, and there are medley particles that carry a negative charge in the extracellular space, but it's around 3, possibly 5 milliequivalents per litre. Effectively though, all the cations must equal all the anions, and the cations are relatively fixed, and they're principally sodium plus potassium. The anions are represented by chloride, around 105 milliequivalents per litre, bicarbonate, 24 milliequivalents per litre, and then everything else. And that's about 15 milliequivalents per litre. And as I've just mentioned, most of that is albumin, about 2/3 of it's albumin. And that's known as the anion gap, the difference between the easily measured charges of cations and the easily measured charges of anions. Bear in mind that the lactate and the ketones that are easily measured these days were not part of the original anion gap. So, if a patient became acutely ill and developed a lactic acidosis, there is 12 millimoles of lactate in the system, then this results in a milliequivalent per milliequivalent reduction in the bicarbonate. So if the lactate is 12, the bicarbonate drops from 24 to 12, and there's a base deficit of -12. If you were to calculate out the anion gap, sodium plus the potassium minus the chloride and the bicarbonate, it would appear that that gap has widened. And it's widened because you hadn't measured the lactate or other unmeasured anions, such as metabolic junk products that we associate with acute kidney injury. And that's where the anion gap really is useful these days. If you put in the lactate and you put in the ketones, everything that's left over are unmeasured anions. Our patient had 3 litres of isotonic saline solution administered, so the sodium and the potassium actually went up to 150 milliequivalents per litre and 5 milliequivalents per litre. The chloride goes up by a significant amount to 125 milliequivalents per litre from 105. As a consequence of this, the rise in the chloride is balanced by a reduction in the bicarbonate. In this case, the bicarbonate drops to 17 milliequivalents per litre, and the anion gap is unchanged or slightly narrowed to 13 milliequivalents per litre. So this is a normal anion gap acidosis. Be aware that the anion gap in this scenario actually narrows a little bit because of the dilution of albumin and unmeasured anions, and the reduction in the bicarbonate is much less than you would expect from the rise in the chloride because the sodium and potassium also had gone up. So there are multiple things actually going on in hyperchloremic acidosis. There is a combination of dilution, hypernatremia, and hyperchloremia. But whatever way you look at it, a normal anion gap acidosis is always a hyperchloremic acidosis. And I often wonder why people even use the term normal anion gap acidosis. Either the gap is widened or it's hyperchloremic. The anion gap actually may be widened with a hyperchloremic acidosis because of concomitant unmeasured anions being present. We typically see this in patients with diabetic ketoacidosis who've been resuscitated with isotonic saline solution. The anion gap can be normal despite significant unmeasured anions being present because of hypoalbuminemia. Remember, the lower the albumin, the narrower the anion gap should be. Regardless, if you have a base deficit or a low bicarbonate, in other words, metabolic acidosis, you must measure the lactate, the ketones, the urea, and the creatinine. Hyperchloremic acidosis is almost always iatrogenic, and it's usually caused by resuscitation fluids. These are the various resuscitation fluids that we used in our clinical practice, starting at the top with isotonic saline, and there's normal salt plasmolite, Hartmann solution, or Ringer's lactate. They're slightly different. I'm just going to narrow this in and show you the crystalloid strong ion difference between the sodium and the chloride for each one of these fluids. Saline, the sodium minus chloride strong ion difference is 0. For normal salt and plasmolite, it's 42. And for Hartmann's, it's 20 versus lactated Ringer's 21. So let's just have a look at what crystalloids actually do to acid base.
Crystalloids always dilute plasma water content. This particularly impacts plasma proteins and hemoglobin. Normally, excess water is cleared almost immediately, but during surgery or acute stress, it may be retained. As each of these moieties carries a negative charge, the impact is to reduce the total weak acid pool and induce a metabolic alkalosis. Isotonic saline solution that contains 154 milliequivalents per litre of sodium and 154 milliequivalents per litre of chloride has a strong ion difference of 0. The sodium to chloride ratio is normally 1:1. Normally it's 1.35:1. The plasma chloride increases progressively the more saline you give a patient, and as this is effectively hydrochloric acid, the process is acidifying. Simultaneously though, the serum ATOT, that's the albumin principally, falls due to dilution, which is alkalinizing. The major impact is acidification, but it takes a couple of liters of saline for this to become manifest due to the dilution of albumin.
Now let's look at the balanced salt solutions. Plasmolite 148 contains 140 millimoles of sodium and 98 millimoles per litre of chloride. The sodium to chloride ratio is 1.43:1, not the usual 1.33:1 that we see in extracellular fluid. This increases the strong ion difference and is alkalinizing. The water in the fluid dilutes the weak acids, that's albumin principally, and is alkalinizing. The major impact of this fluid is alkalinization, and that may make it quite attractive in certain forms of metabolic acidosis, for example, diabetic ketoacidosis.
Sodium lactate solution contains 130 millimoles per litre of sodium and 109 or 110 of chloride, depending whether this is lactated ringers or Hartmann's, and it can be an Australian Hartmann's versus a European Hartmann's. The sodium to chloride ratio is 1.18 to 1. So the solution itself is acidifying because it's delivering a little bit more chloride than sodium, but the water is alkalinizing and the fluid is slightly hypotonic and some water enters cells. In modest dosage of, for example, 3 litres, there is no overall impact on acid-base balance. And that's why Stanley Hartmann developed this fluid, to prevent his patients developing hyperchloremic acidosis. Now let's move on and talk about some of the other mechanisms behind hyperchloremic acidosis. I'm going to do an entire tutorial on chloride as part of the fluids course, but I love this title. Chloride is the queen of electrolytes, because everybody focuses on the king, which is sodium, and just forget about chloride, which is bizarre because it's massively important.
I sometimes ask my trainees, what does chloride do in the body? And most of them are stumped, even though they actually know lots about the medical and physiological role of chloride. And it's really important. Remember, it is a big component of regulation of pH in the kidney. The body takes in equimolar concentrations, roughly, of sodium and chloride, so a slight excess of chloride needs to be excreted all the time. And if the patient becomes overloaded with chloride, this may overwork the kidney. It's also a major part of extracellular fluid volume and homeostasis because of osmolality. It's involved in organic solute transport, cell migration, cell proliferation and differentiation. It's involved in stomach acidity, GABA receptors, in sweating. It's also a major component of chloride channels that are all over the body. And there are medley medical problems associated with chloride channels.
Like myotonia congenita, myotonic dystrophy, Bartter syndrome, Dent's disease, nephrogenic diabetes insipidus, cystic fibrosis, some forms of epilepsy, osteopetrosis, and renal tubular acidosis. Now, renal tubular acidosis involves inappropriate renal reabsorption of chloride. And it's a congenital disease, but it can also be acquired, for example, if you give a patient acetazolamide. And it's also a complication of the use of some other drugs, such as pentamidine, amiloride, non-steroidals, some HIV drugs, trimethoprim, etc. Now, renal tubular acidosis involves inappropriate renal reabsorption of chloride. It's a congenital disease, but it can also be induced iatrogenically. If you give a patient acetazolamide, part of what you're doing is preventing chloride from being excreted, so the chloride goes up. And that's why it's frequently used for metabolic alkalosis. It's also a complication of some other drugs, such as pentamidine, amiloride, non-steroidals, some of the HIV drugs, trimethoprim, etc. It's also seen following surgery where urinary diversion was done and ureters are implanted in the small bowel. And what happens there is the chloride is just reabsorbed and it keeps going around and around. I'm just going to show you these tables that are from the journal article that I mentioned earlier on. It's worth pausing the video if you're interested and just having a look at the list of causes of hyperchloremia and renal tubular acidosis. But I'm not going to go through them in detail. So you can pause now. Let's move on and revisit Sarah. Remember, Sarah is 19 years old and has diabetic ketoacidosis complicated by hyperchloremic acidosis. The pH is still low, so what should you do? First thing you should do is stop giving her saline. If she is fully fluid resuscitated at this stage, you will need to give her some more fluid, but that's dextrose used to reboot the Krebs cycle. If she needs further resuscitation, please change her over to sodium lactate solution or plasmolite. Now, when you're seeing a patient with hyperchloremic acidosis, the first question to ask yourself is the chloride below 125 millimoles per litre? This is a random number that I'm choosing, but I think it's a good number. If it is that low or that high, then you ask, do the kidneys work? And if the kidneys are working and the chloride is below 125, usually you're okay. Just do nothing and the patient will get rid of that chloride themselves. So if you have someone in the operating room and you give them 5 liters of saline and the chloride goes up, within a day or two, that will all be gone and everything will be normalized again. Now, if the chloride is higher than 125 millimoles per liter or the kidneys don't work, then you have a problem. And I think the best thing to do in this situation is just to restore the strong ion difference and give the patient sodium bicarbonate. If that doesn't work, or if the patient is anuric, such as our second patient who was going for his kidney transplant, the thing to do is just dialyze him. In our patient's case, you can see that over 24 hours, her sodium that started at 104 went up to 118 and then gradually worked its way back down again. Note also the secondary problem that you see with the management of DKA, and that's a really low potassium. And that's problematic when specific protocols are followed rather than using common sense approaches to managing fluid and electrolytes. A lot of the abnormalities on these labs, if you look at them carefully, are caused by dilution of various extracellular moieties. You can see a 25% fall in albumin. This is the Story equation that was developed by David Story, an Australian intensivist, and it's really handy. The sodium minus the chloride minus 35 should equal 0. If the sodium minus the chloride minus 35 is below 0, so maybe it's minus 4, minus 5, there is a hyperchloremic acidosis present. If the sodium minus the chloride minus 35 is above 0, say plus 1, plus 2, there is a metabolic alkalosis present. That may be a contraction alkalosis or a hypochloremic alkalosis, depending on which way this has developed. Now let's review the tutorial. In this tutorial, we discussed hyperchloremic acidosis, and I explained that it's caused by a reduced sodium to chloride strong ion difference. It's strongly associated with the administration of 0.9% saline solution infusions. It's particularly seen in diabetic ketoacidosis. It's also seen in renal tubular acidosis in patients treated with acetazolamide and urinary diversions. In patients who are given lots of saline who develop an iatrogenic hyperchloremic acidosis, the thing to do is nothing, just leave them alone. They will clear the chloride. If they have problems clearing the chloride, the treatment is to give the patient an infusion of sodium bicarbonate. In the next tutorial, I'm going to move on and review the literature on hyperchloremic acidosis and question whether iatrogenic hyperchloremic acidosis causes organ injury and worsens patient outcomes. I'll see you then, and I guarantee you'll learn something.
So that was hyperchloremic metabolic acidosis. I hope you found it useful. If you did, please subscribe to my channel on YouTube. Follow me at ccmtutorials.org. Give me lots of likes. Give me some comments and suggest to some of your friends at least that they follow my YouTube channel. I'll see you soon.